Welcome to those who are just joining. I'm going to give it another minute so that we get up to our normal live attendance numbers, and then I will introduce Dr. Saeb-Lima. Okay, we're a little past the hour and we're basically at our normal live attendee number. So welcome everyone. It is my sincere pleasure to introduce Dr. Marcela Saeb-Lima. She is a dermatopathologist at the Instituto Nacional de Ciencias Médicas y Nutrición Salvador Zubrian, or INC-MNSZ. And she is an expert in clinical dermatology with a special interest in autoimmune cutaneous diseases, cutaneous infectious diseases, melanocytic and adnexal cutaneous tumors. She's also a guest professor of dermatopathology at the Universidad Autónoma de San Luis Potosí and a guest professor of dermatopathology at IMSS Ciencia in Nuevo León. She's also the professor in charge of teaching dermatopathology in the program at her school. Dr. Saeb-Lima did her medical training at La Salle School of Medicine and did her dermatology residency at the Hospital General with Dr. Manuel Gea Gonzalez in Mexico City. And she did her dermatopathology fellowship at Harvard University in Boston, Massachusetts. And we were just discussing how she took advantage of an opportunity to go train with someone when she read the first edition of a textbook, which I think is really great, a great example of following your true passions and getting the training you need to do what you really love. And speaking of what she really loves, we were discussing in the practice session how much she loves neutrophils and neutrophilic dermatoses, which she will speak about today for Global Derm Talks. So welcome, Dr. Saeb-Lima, and you go ahead and start your lecture.
So thank you very much. I'm really thrilled to be invited to these Global Derm Talks, and your invitation was very kind. So I'm just getting started. So yes, neutrophils are lovely cells that I just got introduced to when I was working in this Instituto de la Nutrición, which is called here in Mexico, Nutri, to make it shorter. So I also work in the ABC Cautret Medical Center, which is a private practice. But most of the cases that I have seen with the neutrophils are from this institution, because this institution a long time ago became one of the very best treating rheumatologic diseases, because one of the directors, he used to investigate in a lot of that, do a lot of research in rheumatology. So a lot of patients that we see here have autoimmune diseases. So neutrophils are very common for us, and we have been introduced to diverse entities which are now considered new or interesting diseases. So neutrophils, though they are part of the cells that defend from us from bacteria, they're not so good. When they're not so good, they're not so good when they are part of the neutrophilic dermatosis. So neutrophilic dermatosis are these clinical and histopathological diverse group of disorders characterized by notorious accumulation of neutrophils in the skin and in rare occasions in some internal organs. Two entities were considered part of this neutrophilic dermatosis, but they were not considered in the autoimmune context. They were more considered in the autoinflammatory context, and there were sweet syndrome and pyoderma gangrenosum. But research have advanced so much that now they're not longer an autoinflammatory or just not only an autoinflammatory entities, but autoinflammatory entities in the context of autoimmunity or malignancy. So where does this neutrophilic dermatosis come from? Well, these were first described by Freya in 1972 as neutrophilic urticarial dermatosis. Then other names came along as SLE, associated neutrophilic dermatosis. Lipsker is an author that has published a lot about neutrophilic dermatosis, and I think he's the one that made up this name. And then later, because we have seen these entities also, we proposed the term autoimmunity-related neutrophilic dermatosis, because it's not just in systemic lupus that we see this neutrophilic dermatosis, but in other autoimmune diseases. So it's not thinking that there's autoimmunity against autoinflammatory. It's actually the context of autoimmunity that is autoinflammatory diseases come along. So neutrophils get very activated. And this was very well explained in a paper from Lipsker. The fusion of these two entities. So the concept was made up in 1991, though it was first described in 1972, but the concept, the real concept of the neutrophilic dermatosis related to autoimmune diseases was made up in 1991. And Ackerman, he described these lesions as systemic lupus erythematosus in the histologic differential diagnosis of non-bullous, non-vasculitic, neutrophilic, inflammatory dermatosis, which was, forgotten, and I think he is right, and you're going to see why in the upcoming lecture. So various entities have been included, and it depends on the author when they publish these entities. Another one that has done a lot of research is Scott Granter from Harvard also. So the first three entities that were included were sweet syndrome, pyoderma gangrenosum, and palisaded neutrophilic granulomatous dermatitis. But as you can see here, there's a paper from Nushin Brinster, who she has done a lot of research also in this neutrophilic dermatosis, and I think her paper came out before ours. But she includes, all these entities in this neutrophilic dermatosis. So neutrophils are their friends or foe. Well, as I have said, in this context of autoimmunity, they have turned into the dark side, as this paper was published. And since then, they have just crossed and turns, instead of being saviors, to be enemies, actually. Why are there enemies? Well, they're enemies because they produce these things which are called nets, that are chromatin fibers with intracellular proteins in the extracellular matrix after activation. They're called nets or traps also. So the mechanism in autoimmunity that we know that activates these nets or the death of the neutrophils, which is called netosis, is that there's first an activation of the immune complex. The plasmacytodendritic cells are involved in this activation through interferon alpha and LL37. And we now know that one dendritic cell can synthesize 1 billion molecules of interferon alpha in 12 hours. And this also interacts with some specific genes in the neutrophils, causing the death of the neutrophils. Producing all these nets into the interstitium. So the circle, it's going on and on, because as long as the neutrophils are dead and they produce the nets, and more interferon is produced, and then the cycle continues. That's why these neutrophilic dermatoses are so chronic. And as I said, there's not just because of interferon alpha and LL37, but there are other paths in which nets are produced in the organism, and they're listed in this paper. So talking about this neutrophilic dermatosis, the prototype of the neutrophilic dermatosis is sweet syndrome. So we decided, well, we as a group, it was a work of a resident here in Nutrición, that she decided to make research about sweet syndrome because we didn't know what was the epidemiology of this entity. So sweet syndrome was first described in 1964 as acute febrile neutrophilic dermatosis, in which inflammatory reactive process was classified into three groups: the idiopathic or classic, the malignant associated, and the drug-induced sweet syndrome. So diagnosis is very challenging when you get neutrophilic dermatosis in the histology and also from the clinical point of view. We wanted to know what was going on in Latin America and mostly in Mexico. So sweet syndrome is characterized by the sudden onset of fever, leukocytosis, neutrophilia, the polymorphic clinical manifestations that we're going to see later, such as plaques and nodules, and the histology shows a lot of neutrophils. So the clinical variants that have been described are the bullous, the pustular, the giant cell cellulitis-like, the necrotizing, and the neutrophilic dermatosis of the dorsal hands. But now we're going to see new entities that I'm going to tell you later. So Sweet syndrome has this, as I said, these three classical settings. It's more common in women from 30 to 50 years of age. And it can be preceded by an upper respiratory or gastrointestinal tract infection. And it can also be associated with inflammatory bowel disease that we were talking just before we started this lecture, and also pregnancy. 21% has an associated malignancy in the literature, and 85% have an associated hematopoietic neoplasm, mostly acute myeloblastic leukemia. So other physiopathology has also been involved, like the human leukocyte antigens linked to Sweet syndrome, which is HLA-B54, and the mutations in MEFB gene has also been related, mostly in hematologic disorders. So the proposed mechanism is the activation of inflammasomes with a further innate immune system involved, and the expression of interleukin-1 and the neutrophils in cutaneous and extracutaneous tissues. So we have the autoimmunity, the neoplastic background, and the activation of these neutrophils, as I said, in infections, pregnancy, inflammatory diseases, drugs, and malignancy. There are diagnostic criteria, the major and the minor criteria. And as I said, we have very few information what is going on with Sweet syndrome in Mexico and mostly in Latin America. So we decided as a group to develop this research to know what were the associations with Sweet syndrome and what was the prognosis of this entity. So since January 1st, 2000 to March 2020, just 20 patients were put together to do this research. We used at least 3 of the major and minor criteria and to involve the patients. So the minor criteria were fever, the presence of an hematologic or solid neoplasm, inflammatory disorders or pregnancy, and the excellent response to corticosteroid or potassium iodide that we still use here in Mexico. And these were the laboratory findings that were considered to include the patients. So these are the results from our research. So there were mostly women involved, around 50 years of age, which is not different from the literature. The disseminated pattern was more common than the localized lesions. The upper extremities, the trunk and head were more affected than lower extremities or the neck. The clinical lesions were mostly, well, it was like even the erythematous plaques, the pseudovesicles, the urticariform lesions, and the pustules. What was most commonly involved was, or associated was the malignancies in 50% and drugs in 15%. The clinical lesions were mostly necrotizing, pustular, and bullous. So if we subclassify the different types of clinical lesions and the clinical manifestations, we still saw that women were more affected. In the necrotizing type was the mostly involved, and the pustular bullous. We had few of the classic and few of the neutrophilic of the dorsum of the hands. As I said, upper extremities and the head were mostly affected. And we had a polymorphous dermatosis in most of the patients. The symptoms, the most common symptom was fever, and followed by pruritus and myalgia and arthralgia. As I said, the associated entities or diseases were mostly 50% were malignancies. Drug-induced were less common, and infections were seen in almost 65% of the cases. Autoimmune diseases were seen in 30% of our cases. And hematologic diseases or malignancies were more common than solid organ neoplasms. In the laboratory, as we consider the major criteria, the leukocytosis, that was the most common, and the neutrophilia was also then followed by the leukocytosis. So in the histology, all the cases were full of neutrophils. Spongiosis and papillary dermal edema was seen in 65% of the cases. Leukocytoclasia was seen in the 100% of the cases because it was one of the criteria. Vasculitis was seen in 55 because you know when you read Sweet syndrome, you think there should be no vasculitis, and we saw it in 55% of our cases. And as the cells involved, well, neutrophils was in 100%, but we had a mixed inflammatory infiltrate in 70% of the cases. And we saw two histologic patterns that I'm going to show you later, the histiocytoid and the cryptococcus-like. So this is the table. I'm not going to go through this, but this was the table that I gathered describing all the histologic findings that were summarized in the table just before this. And treatment, so all the patients, well, 50% respond to prednisone and 5% to dapsone. Dapsone is no longer available or not that easy to obtain here in Mexico. I'm going to show you a case just to exemplify this, what I'm just saying. This is a 46-year-old female that was admitted because of weakness and an anemic syndrome to the institute, and she had a disseminated bilateral symmetric dermatosis involving the trunk, upper extremities, and the head and neck. As I said, those were the most common sites or topography involved in our patients. Prior to her to being admitted at this hospital, she had fatigue, fever, no symptoms related to the dermatosis. So the dermatosis was characterized by these pustules, these erythematous plaques, and the oral cavity was also involved. A diagnosis of herpes was made, like disseminated herpes or varicella zoster, and the sign was negative. So you can see there are also some violaceous plaques with pustules around. So that's why varicella zoster was one of the diagnoses, thinking, the different stages of the lesions in varicella. But she had a personal history of diabetes, arterial hypertension, the anemic syndrome for 2 years, and the bone marrow did show erythroid hyperplasia and a grade 2 myelofibrosis. There was no response to intravenous iron, and she needed blood transfusion. And diagnosis of myelodysplastic syndrome versus acute leukemia was made in her admittance with pancytopenia. The histology showed this superficial and deep neutrophilic diffuse infiltrate with no microorganisms found with the stains, PAS, Phyte, Tite Fareco, and Seal-Nielsen or Crocot or Gram stain. So as you can see, there were a lot of neutrophils with leukocytoclasia, pyrexis involving the subcutaneous tissue. So we could consider this as a necrotizing variant of Sweet syndrome. As I said, no microorganisms were found with the special stains. The same histology was found in the lungs and in a lymph node. And with MRI and CT scans, we could see that there were lesions also in the central nervous system, the lungs, the lymph nodes, the liver, and the spleen. So this is a disseminated Sweet syndrome involving the skin, and she had this myelodysplastic syndrome. So myelodysplastic syndrome is clonal disorder characterized by ineffective hematopoiesis and a tendency to evolve into acute myeloid leukemia. Switch syndrome can present as a predicted matter of this myelodysplastic syndrome months to years before the malignancy develops. And there's an increased mortality seen in patients with myelodysplastic syndrome and neutrophilic dermatosis. So this is just to consider, and these are the kind of cases that we saw. The switch syndrome associated with a hematologic entity or hematologic malignancy, as we saw. So these are other cases of switch syndrome. This is one of the dorsum of the hands. You can see the erythematous plaques with the vesicular kind of appearance. The urticarial or almost erythema multiforme-like lesions. The necrotizing ones with this very elevated border, almost simulating pyoderma gangrenosum. And as I said, the head was less affected, but we could also see lesions there. The histology showed in most of the cases the dermal papillary edema. The neutrophilic infiltrate was scarce or it was very dense, as you can see here. Spongiosis was seen in 50% of the cases, and there was an interface bipolar change in some of them. The karyorrhexis and the nuclear debris was very obvious in almost all of the cases, and this is the cryptococcus-like pattern that we have seen. So if you see these cells, you could think that this is the mucinous stroma seen in cryptococcus, but there was no cryptococcus. This was just the neutrophils giving this appearance of the cryptococcal-like pattern. So we have two cases of this pattern and the histiocytic that I'm going to show you later. You can see the interface, the neutrophils, the karyorrhexis, the dermal papilla, most of the cases involving the subcutaneous tissue, which is now considered a necrotizing pattern or a necrotizing new variant. And you can see the neutrophils attached to the basal layer. So to finish this about, or the research about this switch syndrome that we have seen here in the institute, most of the patients were middle-aged women. Upper extremities, head and trunk were mostly affected. The clinical lesion was more common was erythematous violaceous plaques. The most common malignancy was an hematologic neoplasm in 38% of the cases. And as I told you, autoimmunity was also seen, and infections were also associated entities that accompanied this switch syndrome. So it is still a very rare disorder. In 20 years, just 20 patients is not that much, but we could analyze the associations, the clinical pattern, the histology, including the immunohistochemistry. And so I think briefly the resident, that she's no longer a resident, but she can publish what we saw, and you can have that in the literature. So after this, I'm going to go into the neutrophilic dermatosis and autoimmunity. So we were invited to publish in this Ronco Gauletti and Bruce Smoller book, the new and emerging entities in dermatology and dermatopathology. So we included the new neutrophilic dermatosis. As I said, neutrophilic dermatosis related to autoimmunity. So in this, we consider to include the necrotizing neutrophilic dermatosis. So this necrotizing neutrophilic dermatosis was first described or proposed by Krosinski in 2012, because there were a lot of cases published in the literature. So instead of calling it syndrome-like, so they said, no, we have to classify it as a necrotizing neutrophilic dermatosis, but it's still part of switch syndrome. And Sanchez and co-workers, they said, well, just call them necrotizing neutrophilic dermatosis in this paper in JAMA or JAMA. So the clinical features is pathogy, as we see it in pyoderma gangrenosum, erythematosus to violaceous papules, plaques, pustules leading to skin breakdown and lack of crepitus, which is no different from the necrotizing variant of Sweet syndrome. And they propose major criteria, major components, which was previously mentioned clinical characteristics, systemic involvement, which could include shock, fever, or leukemioid reaction, the absence of infectious organisms in the skin, and the histology compatible to features and adequate response to treatment. So the minor criteria were previous history of pathogy and the presence of comorbidities, that they don't differ very much from Sweet syndrome. As I said, this is a variant of Sweet syndrome, the necrotizing neutrophilic dermatosis, but it's more exacerbated. As I said, in the histology, there's a lot of inflammation from the dermis to the subcutaneous tissue. The cells involved are predominantly neutrophils with associated leukocytoplasia and edema. Neutrophils are associated with necrosis in less than 50% of the cases, and they can also extend to the fascia and muscle. There's evidence of vasculitis or atypical or immature myeloid infiltrate was not seen, which is different from what we saw. In our cases, we did see vasculitis. So this necrotizing neutrophilic dermatosis can resemble necrotizing fasciitis, and one has to make the differential diagnosis by doing the specific stains for that. They say that opposed to typical Sweet syndrome, the infiltrate goes deep down to the fat and, as I said, to the fascia and subcutaneous and the skeletal musculature. So it's a very deep Sweet syndrome. They said that the theories that suggest that this is an entity, they say there are pro-inflammatory cytokines like interleukin-1, interleukin-8, G-CSF, GM-CSF, and interferon gamma, which promotes the chemotaxis of the neutrophils and the injury and the myonecrosis that has been seen in these cases. And this can result in an extracutaneous involvement in renal, hepatic, or cardiac dysfunction. The case that I show you actually is this necrotizing dermatosis that was involved in the systemic nervous system and the lungs and the liver and the spleen. So the histology shows this very deep neutrophilic infiltrate with leukocytoplasia involved in the subcutaneous tissue and we didn't put the picture of the fascia and the muscles because we didn't have that deep biopsy. So whenever you see this, you have to suggest to the clinicians to make a very deep biopsy, not just a punch biopsy. So this variant of Sweet syndrome, it's another one, the histiocytic autoimmunity-related neutrophilic dermatosis. So the context is this Sweet syndrome, but 41 years later, just to make it short, Requena said, from the histology point of view, this is not just Sweet syndrome. This has other histologic criteria. So the clinical is very similar to Sweet syndrome, but in the histology, and also the associated entities are very similar to what we have seen in Sweet syndrome. But as I said, the histology is the one that is different. So you can have spongiosis and exocytosis on inflammatory cells and even a backwaller change in the basal layer. But there's a dense infiltrate, which is composed of these mononuclear infiltrate, which have pale, vesicular viable shaped nuclei with moderate amounts of amphophilic cytoplasm, mild atypia, elongated nuclei, or symphyginous in the outline, accompanied by inconspicuous lymphocytic infiltrate in the perivascular zones, and neutrophils scatter irregularly among the mononuclear cells. So you see mostly these mononuclear cells infiltrating the dermis. Those are positive for CD15, CD43, CD68, and CD163, confirming the macrophage and monocytic lineage. They can also express lysozyme. There's variable staining with CD14, TCL1 oncogene, HLA-DR, and CD123. The accompanied lymphoinfiltrate is usually CD3 positive, and there are few CD20 lymphocytes. The clinical differential diagnosis includes all of these: drug reactions, Well syndrome, sarcoidosis, erythema levatum diutinum, granuloma annulare, erythema multiforme, polymorphous light eruption, and dermatomyositis. This is from the clinical point of view. But from the histology point of view, seeing those mononuclear cells, interstitial granuloma annulare should be considered. Eartham-Chester disease is also has to be considered, and this RAS-associated autoimmune leukoproliferative disease should also be considered. So this is a case of this histiocytic. You see the dermal edema, the papillary dermal edema, the neutrophilic infiltrate, the backwaller change, but the cells that we can see, there are also CD68 positive, CD34 positive, also the lymphocytes are CD3 and CD4 positive, and some of them are CD8 positive, and the neutrophils are also shown with the myeloperoxidase. So you see these mononuclear cells that are CD68 positive in the histiocytic immune variant. So just moving from Sweet syndrome and its variants, the necrotizing and the histiocytoid, we're going to go into the amicrobial pustulosis of the folds associated with autoimmune disorder, which was first described by Griggs in 1991, which is a red pustular dermatosis mostly affecting women. It's recurrent, and it has follicular and non-follicular pustules, false and periorificial scalp and anogenital areas are also involved. And they were mostly described in systemic lupus, but we saw a case not only associated with systemic lupus, but with autoimmune hepatitis. So we published this in 2013 in this journal. So we showed 5 cases, 5 were women. 5 women. 4 were had systemic lupus, and 1 had autoimmune hepatitis. They were mostly between the 21 and 50 years. And this patient had the autoimmune cirrhosis and the pustular dermatosis. And as I said, from 21 to 50 years of age, which is very common in the systemic lupus erythematosus patients. But in this case, we saw the autoimmune hepatitis. So most of the patients had this disseminated bilateral, mostly symmetrical dermatosis affecting the trunk and the extremities, composed of pustules in an erythematous base. And the folds were mostly affected. But around the periorificial areas, in the anogenital, the mouth, around the ears, and in the scalp, and in some folds, we also saw these eczematous plaques, like it was atopic dermatitis. But the pustules were there all the time. So in the context of autoimmunity, these eczematous plaques and the pustules made the diagnosis of this autoimmune-related amicrobial pustulosis of the folds, which by histology is nothing specific. You see the subcorneal pustules, some spongiosis, the inflammatory infiltrate, which is composed mostly of neutrophils, but also lymphocytes. And there's always no microorganisms identified. So these cases were very difficult to diagnose because we had a lot of biopsies, and actually it was the dermatologist that made the diagnosis, Rocío Orozco. So she put all these cases together. So with the clinical pathological correlation matched very well. And all of these patients had these autoimmunity related entities. As I said, this is the neutrophil seen in these biopsies. An spongitic pustule was observed. The differential diagnosis should include all the pustular dermatitis with no acantholysis. And this comes in the spectrum of this neutrophilic dermatosis, where there's more expression of interleukin-1 and TNF-alpha, and less expression of this other interleukin B and fibroblast growth factor or vascular endothelial growth factor. So it's mostly dependent on interleukin-1 and also interferon alpha. So another entity is the autoimmune-related neutrophilic dermatosis that we propose, just not to call it systemic lupus erythematosus related neutrophilic dermatosis, but autoimmunity, because we saw one patient with arthritis from rheumatoid arthritis and Sjogren's syndrome. There was a paper that included 7 cases, 6 female patients and 1 male. Most of them had these macules, papules, and urticariform plaques. In histology, the neutrophilic dermatosis was seen with vascular interface changes, leukocytoclasia, and no vasculitis. And I'm saying no vasculitis because the clinical diagnosis was usually urticarial vasculitis. So we saw these cases and said there's no vasculitis, so we put them together and we came with this diagnosis. Later, we made the immunofluorescence, what I'm going to show you, but in this first report, we didn't include the immunofluorescence of these patients. And as I said, in 1996, Bernard Ackerman called this entity systemic lupus erythematosus non-bullous, non-vasculitic. And I'm going to show you why it's very important. So the clinical lesions were these urticarial plaques. Some of them even look purpuric. They leave no pigmentation or scar, and the epidermis was usually flat with this vacuolar change, and the superficial neutrophilic infiltrate with a lot of leukocytoclasia. And as you see, the interface changes with no vasculitis. And as I said, later we put together 5 cases where we saw the deposition of immunocomplex IgG and IgM in the dermoepidermal junction, not in the vessel walls. And these cases all had these systemic or autoimmune-related entities. 1 had rheumatoid arthritis and 4 had systemic lupus, mostly female and just 1 male. And the clinical lesions were very similar. They were very active, actually. When the lesions came out, they were very active in the systemic lupus or the rheumatoid arthritis. And as I said, after we saw these patients, 3 of these ones that we made the immunofluorescence developed bullous lupus. So Ackerman was right. This is a non-bullous, or it's a frustrated non-bullous, but after a while they can develop bullous lupus. So we have to make sure that this is like maybe this is a variant of the autoimmune-related neutrophilic dermatosis, or this is a variant of systemic lupus that it's frustrated for a while. I don't know. Maybe this is something to discuss in the literature or with you. And I'm just talking about lupus erythematosus, even though it's not a new entity or nothing to do with it, but because we talk about this autoimmune-related neutrophilic dermatosis that can develop lupus, just not forget that lupus erythematosus can show this facial erythema with the butterfly appearance, and then the bullous lesions in the sun-exposed areas, and then in the non-sun-exposed areas. You should usually see this damage to the dermoepidermal junction by the neutrophils, and you can, in some patients, you can even see vasculitis in bullous lupus. Dermal edema is usually present, and the subepidermal bullous filled with neutrophils. So this is an autoimmunity against collagen 7 with linear deposits of IgM, IgG, IgA even, and it improves with Dapsone. It affects mostly female with vesicles and bulla, and lesions are disseminated, but as I said, first they are sun exposed and then they appear later in not sun-exposed areas. This is the immunofluorescence, where you can see, as I said, IgG, IgA, or IgM positivity in a linear pattern. And then I'm going to just close this this lecture with this discussion case, because we have, as I said, we have seen a lot of neutrophilic dermatosis. And I think this is a new entity. I think we have almost 3 or 4 cases of this that I'm going to show you right now. So this is a female patient that was admitted to the hospital when she was 18 years old, and she's from Mexico, and she had this generalized dermatosis. She had these plaques, erythematous plaques, these eczematous plaques around the periorificial area. Then she developed later, 1 day later, the lesions were confluent, and the eczematous plaques were more apparent, as you can see here. And this has this appearance of the amicrobial pustulosis of the falls, if you follow me. And then, but in the trunk, she developed these annular plaques, as you can see in subacute lupus erythematosus. And she also developed these pustules. So we have this very polymorphic dermatosis with eczematous plaques, pustules, annular plaques, as you can see in subacute cutaneous lupus. Almost in some areas, they look like very erythema multiforme-like, and then just erythema in the back. And again, these EM-like lesions in the extremities. So she had rheumatoid arthritis when she was 13 years old. Oh, well, she was diagnosed with rheumatoid arthritis, but in 2015, a diagnosis of systemic lupus was made, affecting the articular, dermatologic, and renal organs. And she had a secondary antiphospholipid syndrome with deep venous thrombosis. She was in this treatment, but because of economic problems, she couldn't get all the drugs. But the latest drug she got, it was enalapril, because of a hypertension that was detected. And after she ingested the enalapril, the dermatosis appeared. So she was diagnosed initially as an urticaria. The enalapril was suspended. That was the last drug she took, and they gave her losartan and loratadine. She had activity of her systemic lupus in other organs, as the urine and the blood. And 2 biopsies, 2 punch biopsies were taken, and the histology showed these subepidermal pustules, this spongiosis, the dermal edema, the dermal papillary edema, and the superficial neutrophilic infiltrate. You see the pustules, the subcorneal pustules, the edema, the neutrophils. There was also leukocytoplasia. And we couldn't make up a diagnosis here because it was not the amicrobial pustulosis of the folds. This is not autoimmune neutrophilic dermatosis, because there's a lot of dermal edema and the subcorneal pustules that we have never seen in the autoimmunity-related neutrophilic dermatosis, or the urticarial dermatosis, which somebody called them. This is not a sweet syndrome, because the infiltrate is not that much, and the clinical appearance is not that of a sweet syndrome, even though the pustules you can see. And this is not an amicrobial pustulosis of the folds, because in the amicrobial pustulosis of the folds, you don't see these EM-like lesions or the annular subacute cutaneous type of lesions. So we have this polymorphic histology and this polymorphic clinical features. And I think, well, this is just to show you the neutrophils and the lymphocytes around the vessels. She recovered from the dermatosis, and she could get out of the hospital. I don't think we have seen her later after we saw her in those years. So, but after this case, we have seen 3 or 4 cases showing the same histology, showing the same clinical as features with these EM-like pustules, eczematous plaques, and most of them have this autoimmunity, context, and the drug, which triggers the manifestations. In this patient, the immunofluorescence was positive in the dermal junction with IgG. So as you can see, we have a mixture of this autoimmune-related, and I think this is a new entity of a neutrophilic dermatosis with pustules, the neutrophils, the positivity for the autoimmune complex, IgG predominantly, and then the polymorphos with features with the pustules, the eczema, and the annular plaques. So I think this is a new thing that we're cooking, and I hope that sooner than later we can publish these cases and include a new variant of neutrophilic dermatosis. And I think I'm on time. Yes, I'm on time. So, so thank you very much. If you have any comments, questions, criticisms, or anything, just give it to me.
Thank you so much. This was such a wonderful talk. I actually have two questions. We have an audience question, and Bill has a question that I will field for him. So let's go with the audience member first. This is a question from Ahmed. They are asking, did you consider AGEP, AHEP, for the last patient that you presented?
Yeah. That's another very good differential diagnosis. The thing is that, and it comes in the discussion, is that it cannot be the eczematous pustular generalized dermatosis, because you don't see the annular plaques in a JEP. You don't see the neutrophils in the infiltrate below. You just see the pustules, up, like the amicrobial pustulosis of the folds. And in a JEP, you don't see the eczematous plaques. You saw around the periorificial areas and around the ears, and you don't see that in a JEP. So you could see the disseminated pustules, but the dermal edema doesn't go with that. The immunopositivity, the IgG, the dermal epidermal junction doesn't fit. So even though you can consider that as a differential diagnosis, which is a very good differential diagnosis, there are a lot of other things going on that you cannot explain just by the AJEP. Yeah,
makes sense. So my question is maybe a little naive, not being formally trained in dermatopathology. One thing that really struck me with, especially like the histiocytic lesions you were showing, or even the lesions from the last patient, is that dermal edema, and it looks like it forces all of the immune cells down. So you have like that band down there, and then the edema at the top. And I was just curious, like, is that common? Like, do the immune cells ever infiltrate the fluid? Is that something that we're missing, like when we actually cut the tissue for the architecture? It just seems interesting. It's almost like it was like chemorepulsion, like the cells got pushed down.
I see what you're saying. Yes. No. Well, in sweet syndrome, you see some of the neutrophils there, just floating, but few. Yeah, it's almost everything's pushed down, as you said. In the histiocytic variant of sweet syndrome, that you also see this dermal papillary edema. Not just few neutrophils. Very few neutrophils, you see them. And in this new case, you saw that there's a lot of edema and the infiltrate just goes down. Yes, I think there's nothing going on in the fluid, in the fluid down there. It's just, they cannot be together. I think cytokines and chemotactines get lost in there. So that's why you cannot longer have the cells up there. And I think it's mostly that it's just fluid, and it just, like it dissolves all the chemotactines, the interleukins, and everything else. So yeah, it's pushed down. And we saw that in the histiocytic variant of sweet syndrome, in this new case. And where we don't see it is in the amicrobial pustulosis, or in this autoimmune-related neutrophilic urticarial dermatosis. But in the other one, yes, there's the fluid down there. We could, if we could be very specific and, measure the interleukins in the dermal edema, and then the interleukins, I don't know if you can do that, divide the, the biopsy and measure the interleukins, because we have measured interferon, and we have measured, I think it's interleukin-1 in our cases, and there's a lot of interferon, but it's all over the biopsy, but not divided into these two areas. Yes, but it's very interesting. Yeah,
thank you. So Bill's question was about special stains. So other than looking for organisms with special stains, are there any histologic markers that you find useful for differentiating infection from autoimmune neutrophils? For example, some have looked at CD123 staining in lupus, but I'm not sure if it has been studied in neutrophilic manifestations.
Okay, it's not just the stains that we do in the biopsy. There's always biopsy done for tissue culture. So we make sure that we didn't miss microorganisms. So all biopsies are cultured, and we make sure there's no microorganisms, because in that Cryptococcus-like pattern, you saw that, you could think that there's Cryptococcus, but no, it's just neutrophils that are in this matrix, very, very liquid matrix. But no, we make the special stains, we make the culture, and I don't do CD123 because I don't know. I think I have made it just once, because it's sometimes so obvious, the neutrophilia with the leukocytoclasia, that the only way you can explain that is with this, because even though you have some karyoretic debris in infectious diseases, because we see a lot of mycobacteria here in Mexico, the atypical and the TB mycobacteria, they don't do this karyorexis. Even though you have, this bunch of neutrophils in the subcutaneous tissue and with mycobacteria or fungi, you don't see this amount of karyorexis. And I think that's a very good clue for that, making sure that in the culture you don't have anything, and making sure that in the special stains you also don't see any microorganisms. But I don't think you could, if you do an MPA, meloperoxidase, well, you're going to have it both. If you do the CD133, it's just maybe to show sometimes, like in the histiocytic variant, that you have SLE associated, but it's better just to ask the patient, the clinical, all the clinical, that there's autoimmunity down there. So I think it's just that I just followed that to make the diagnosis of this neutrophilic dermatosis. Leukocytoclasia, I think it's a very good feature of these entities.
Awesome, Thank you. Now we have a question from Anshu. Sorry if I'm saying your name wrong. They ask, I have never really understood the mechanism of pathergy. Do you have any insights into this?
Well, yeah, there's, so this trauma stimulates the interleukins and the cytokines. So in the context of autoimmunity, which is usually seen in all these patients with pyoderma gangrenosum or Crohn's disease, or now that we were talking. So you have a context of something, and then you have this stimulus that gathers because you solve the superficial epidermis, then bacteria can come in. They can be super antigens, and they just start attracting the interleukin, interleukin-1, the interferon alpha, the LL37, and then it starts with a few, and then it just goes on and on. So I think you have to have the context with the discontinuous epidermis. Then the bacteria can act as a super antigen, and then stimulate the interleukins, and then you have all these things. Yeah, but I think it's something like that. You have the super antigen, and then the context, and then all this. That is, I think, it's well programmed I mean, in this autoimmunity context, is well programmed that autoinflammatory things are going to happen. Yep.
Yeah, thank you.
Something like that.
We have another question from Ahmed. What is the difference between pustular dermatosis of the folds and Sneddon-Wilkinson syndrome or subcorneal pustular dermatosis?
So again, it's a clinical setting. Just remember, this is only in the context of autoimmunity. So if you have autoimmunity and you have these pustular lesions that are disseminated, and the difference from the clinical point of view, Sneddon's, you know that it starts with the folds and then it gets disseminated, but you don't have the eczematous plaques that you see in the amicrobial pustulosis. That's a clinical thing that you don't see in Sneddon's. And the other thing is the autoimmunity context. So as I said when I started the lecture, is the good thing of this institute is that it gathers almost all the rheumatoid patients. So we are able to study a lot of phenomena that are occurring in these patients. So we always think that this is autoimmunity related. So that's in my mind all the time. And as we see that, that's when you can see it. I think I have never diagnosed as Sneddon-Wilkinson in my life. Actually, even though I see a lot of pustules, subcorneal pustules, and you do the exercise of excluding candida, trichophyton, dermatophytes, the amicrobial pustulosis of the folds of childhood, the amicrobial pustulosis, acropustulosis of childhood, and then and the other differential diagnosis, I have never made the diagnosis of a Sneddon-Wilkinson. Sorry. I always get a candida or a dermatophyte or something, or this amicrobial pustulosis of the folds, but no Sneddon. I don't even think that's an entity. I don't know.
I mean, maybe it's up for debate. I don't know that much granularity, but yeah, thank you. And then one last question about the autoimmunity. Have you ever looked at the IgG subclass in the lupus interface, in the lupus band reaction? I'm just curious because I've been reading some literature about how Th1 versus Th2 skewing can kind of instruct different IgG subclass, and I don't know like if that's significant on derm path or not.
Well, we haven't done that. That's the short question. That's the short question. I mean, that's the short answer. We haven't done the subtypes of the IgG. So and we haven't figured out by serum, which is the Th1 or Th2, or how interleukins are in these patients. We just did that in some biopsies. It would be very interesting because we have maybe rheumatology could do that, and I have to talk to them, and maybe we could do more research about that. And about talking about immunofluorescence, we always miss that because you see the patient, you see autoimmunity, and you say this is urticarial vasculitis, and that's how we found these 7 patients, because say there's no vasculitis, there has to be something else. So when we put all these cases together, we came to this. For this urticarial dermatosis that Lipsker described and Ackerman described as the non-bullous, non-vasculitic dermatosis. But we missed the patient, you just take the biopsy and then you miss the patient. But years came by and I said, please just take a biopsy. When you think of urticarial vasculitis, take a biopsy for immunofluorescence, and that's why we just have 5 cases, just 5. We could just do the immunofluorescence, and there's the IgG and the IgM, but we couldn't subclassify that. I'm sorry. We'll try.
I think it's amazing, like being able to do that level of detective work, basically, to figure out exactly what's going on in your patients. So thank you so much. This was a great talk. I learned a lot. Obviously, we had great questions from the audience members, and they're all saying in the chat that they really appreciate your lectures. So thank you so much.
No, thank you.
All right.
No, thank you.
Well,
thank you very much.
Of course, and we're at 1 o'clock, so will everybody go? I did want to mention one thing, one announcement before we go. We do have a survey for our attendees because we're starting to schedule content for the next academic year. And we're also trying to help Thea, who just matched for dermatology residency, complete her pedagogy paper about the work we've been doing with global derm talks during the pandemic. So if you are willing to answer the survey, the attendee survey, we would really appreciate that. And we'll post the link again on the Twitter account. So thanks again, everybody who was able to attend live. And thank you so much, Dr. Saeb-Lima. It was a great talk. All right, thanks everyone.
Thank you so much. Have a lovely day. Thank you.